Welcome to our roundtable. I'm Jamile Shammo, a hematologist from Northwestern University. And today we're going to be talking about treatment options, specifically focusing on patients with low-risk MDS in first-line setting. Today I am joined by a panel of experts, and I would like them to introduce themselves.
Hello, I am Melhem Solh from the bone marrow transplant at Northside Hospital, Atlanta, Georgia.
Hi, I'm Somedeb Ball from Vanderbilt University Medical Center in Nashville, Tennessee.
Hello, my name is Bart Scott. I'm from the Fred Hutchinson Cancer Center in Seattle, Washington.
Hi, I'm Palmisiano from Rutgers Cancer Institute.
And hello, I'm David Swoboda from Tampa General Cancer Institute.
And our goal today is to talk about how do they decide on what to choose in terms of treatment for patients who have MDS. What is their timing for initiation of therapy, and what is the sequence that they would utilize in this setting? Today, we're going to be discussing treatment options for low-risk MDS in particular, focusing on timing for initiation of therapy and choice of therapy as governed by certain parameters, perhaps transfusion need or other biological markers, etc. Maybe we can go on to real-world data. It seems to be an ongoing trend right now that everybody is putting out real-world data. And I guess the rationale for that is that not all patients will qualify for clinical trials, and perhaps we can learn something from real-world data. So has there been anything in this conference that we are attending that has impacted your preferences or treatment options at this point relative to real-world data?
Well, real-world data does have issues. There's an issue with misclassification. It's retrospective. It's not randomized data. There's a selection bias of who is chosen to be assessed in a real-world evidence study. Many of these real-world evidence studies don't have great information on actual diagnosis. So sometimes they're just anemic, and you don't really know for sure that they have MDS. But with all of that being said, there is some evidence that's being presented and has been presented showing that the real-world evidence with Luspatercept really mimics what was seen in the COMMANDS trial. So that's encouraging. And I think the benefit of the real-world evidence is it gets around the issue of generalizability with clinical trials, because when we do our clinical trials, we work in what we call a white ivory tower. We have patients of higher socioeconomic status, generally good insurance support, very highly compliant. And so people are concerned that clinical trial data isn't generalizable to a broader population. So being able to see the real-world evidence that supports the use of Luspatercept is encouraging.
Yeah, no, I definitely agree. I think, a lot of times we select for that ideal patient population. And, like even this is not published at this ASH, but a previous, EHA or ASH, they published data on just ESAs. And, we have this, from the COMMANDS data, we show that, the ESA response rate was much higher than what actually is occurring in the real world, where it's probably closer to 20% in most patients, transfusion and events rate. So I think, like Dr. Scott said, it just really just adds to what we're seeing on the studies, and helps us to find little subsets of patient populations that we might never be able to really run a study on and get access to that data.
And often, like when I'm talking to community docs or my referral base, I get asked this question often. So we all, prior to the Luspatercept data, utilized erythropoietin, ESAs, right, for patients who had anemia. But now that there's more of a shift for Luspatercept in first line, a lot of times people ask, well, can I use EPO, and what are the data on EPO post Luspatercept? And frankly, the data were very, if even available, but this real-world data analysis that Dr. Sekeres kind of put out this meeting tackled exactly that. So not only did they show an agreement with what Dr. Scott was saying, in that the results with Luspatercept in first line were comparable to what you saw in the study, But then they also showed that the subset of patients who came off study or off treatment with luspatercept rather, had a very similar response rate to ESA in first line, was about 40%. So that is very interesting. I mean, I realize that the number is really small and this is real world and it's not totally randomized, but, and of course we don't know what their EPO level was before they started, but you would imagine that it must have been below 500, but it would be nice to know what was the EPO level. I mean, that's in a way comforting to know that you still have the ability to utilize EPO in second line.
And
Any
that's,
thoughts?
a question we get asked by community physicians a lot. Somebody progressing on luspatercept, can I start them on ESAs? And true, we don't have much data. I mean, my answer would be, well, check the EPO level if it's low. I mean, that's very likely the right answer to do at this point. I don't know how y'all's advise on that topic.
So I think one thing I would, first thing in my mind when I talk to community physicians is, what do you mean by progressed on luspatercept? Just trying to learn that a little more, because a lot of times I see, okay, 1 milligram per kilogram dose being tried for a few months and that's it, or 1 to 1.33 and that's it. We need to make sure that we are actually utilizing the highest dose possible, 1.75, especially after the data that we highlighted that clearly the responses are better in the higher dose starting first. But if we are not starting with the highest dose first, at least going by the level, we should make sure that we are utilizing the highest dose level first before calling a progression. And then sometimes, and anecdotally I have seen that adding ESA to luspatercept has salvaged some of my patients' response, and there is data published from Moffitt Group, Dr. Komrochi a few years back on that. That combination can sometimes improve the response rate in this population. Very low, but it's possible. Especially I would, as an anecdote itself, like, there's a patient, ring sideroblast, with this RSF2 mutation, progressed or did not, got benefit from luspatercept, went to highest dose, but then it plateaued and was not improving. We added ESA and we were able to again get a durable response for a while. So there are those patient subsets there we can try. There is no clinical trial data at this time, of course.
I still see patients in consultation that are not dose escalated and it's still at the one dose who are not responding.
Yes.
And it's surprising to me, and there's real world evidence speaking of that, showing that in the practice setting, many patients are discontinued without dose escalation from their luspatercept. So I still think that's an important message for all of us to send to the community at large, that dose escalation should occur. And the Maximus trial is going to help a lot with that.
Yeah, and I think the Maximus trial is actually very interesting from a patient perspective, because 3 months is a long time to wait to get to the maximal dose of that medicine. And I think the ability of that to start at the highest dose and tailor it to patients' needs is very patient friendly.
We always have to remind people that the assessment of response happened at 24 weeks, right? So, and yes, you titrated the hemoglobin between 10 and 12, and so it's essential that you sort of get to that point before you can call it quits. And I totally agree that there's data suggesting that people don't even get to what is recommended, essentially.
Yeah, and I think the whole rationale of this up-titration really came from beta thalassemia and this clot risk, which we've sort of proven is not seen in MDS. And even I think there's a poster that looks at luspatercept versus ESA and clotting risk, and actually showed that luspatercept had a low clotting risk than ESAs in general. And so, I think we're getting rid of that, and I think all of us are very comfortable with the higher dose, not feeling like increasing hemoglobin luspatercept is increasing clotting risk, and so I think it'll be really helpful to make sure that the patients get the maximum benefit from the drug before getting off the drug.
I also came across one other real-world data, a study that kind of compared how many patients can attain a hemoglobin of greater than 10 grams in a real-world setting, and comparing ESAs to luspatercept. Though it's difficult to say that you can extrapolate the data to clinical practice, because it appears that the responses, even though better with luspatercept, but there were more patients who had ring sideroblast in the luspatercept arm than ring sideroblast positive in the ESA. So that also goes to show you that the adoption of luspatercept in the ring sideroblast negative is still behind what we all have been talking about, but it is kind of interesting. So you have to, when you read real-world data analyses, you have to really focus on the type of patients that were included. Nevertheless, I think attaining hemoglobin greater than 10 grams has been shown, at least in that Oliva's analysis of the commands, that it's associated with better quality of life. And I'm a firm believer, but I think we need more data to support that type of a conclusion. But I'm curious.
We presented data from a prospective study I was part of during my time at Moffitt last year at ASH, where it was more 120-something patients with MDS, majority were lower risk MDS, and hemoglobin 10 came up there and we looked at like QUAMS, which is a validated tool to measure quality of life in MDS patients, and anemia with hemoglobin less than 10, along with transfusion dependence, both came up as an independent factor associated with a poor quality of life, particularly the physical burden. So, it's a single institution prospective study, but I think there is enough data to suggest. Of course, it's subjective as well to some extent. Some patient I see with hemoglobin 11, they still have fatigue. We have to realize MDS, the disease is still there, regardless of whether anemia is below, like hemoglobin is below a certain number. I mean, part of the fatigue comes from MDS itself. Part of the fatigue is anemia. So that factor is there, but in general, people who are anemic, yes, 10 is a decent number from multiple different real-world studies coming up, to focus on as a measure of probably anemia burden or disease burden, so to speak. Yeah.
Well, I'd like to thank the panel for a provocative discussion on the management of low-risk MDS. Thank you all for participating.
Thank you.
And thank you for joining us.
Thank you.
Thank you.
Thank you.